Ladies and gentlemen, please welcome Dr. Charles Hart, Premier Board Member and President and CEO of Regional Health in South Dakota.
Thank you. Well, good morning. I'm Dr. Charles Hart, Premier Board Member and President and CEO of Regional Health in Rapid City, South Dakota, home of beautiful Mount Rushmore. I hope you enjoyed the concurrent sessions this morning. Lots of valuable information was shared on the U.S. healthcare system and our mandates for transformation. Our next speaker will provide some international perspectives on population health, cost, and quality in Scotland. Let me tell you a little bit about him. Derek Feely has been Director General of Health and Chief Executive of the National Health Service in Scotland since November 2010. In January 2011, his Director General role was extended to cover health and social care, making him the principal advisor to the Scottish ministers on these issues, providing direction to the work of the NHS boards and assuring the delivery of high-quality health care. Derek is a career civil servant with an extensive background in policy analysis. Earlier in his career, he was Principal Private Secretary to Scotland's First Minister, where he developed a framework for service redesign in the NHS. As a Harkness Health Fellow Foundation in healthcare policy, he spent a year in the United States working on healthcare issues and then was appointed Director of Healthcare Policy and Strategy on his return to Scotland. In that role, he was responsible for advising the Scottish Government on all healthcare quality issues, including patient safety, and he also led their efforts on healthcare information transformation. He brings a wealth of practical knowledge to us today. Please join me in welcoming Derek Feely.
Thank you, Charles. So good morning, everyone. You've spotted already I have an accent. And I thought the first thing I should explain probably is the strange job title. So I've got two roles, really. Firstly, as the advisor to the Scottish Government, principal advisor on health and healthcare, and then in the chief executive role in the delivery of that policy. So I have no excuse for making bad policy. I need to implement it. That's our novel idea, isn't it? I should say something about what this isn't. So I'm not going to offer you any prescription, because I don't think there is one. I'm not going to make too many predictions. I think I'm going to talk a bit about the future, but I think it was Sam Goldwyn-Mayer that said, I never make predictions, especially about the future. All I'm going to do is set out our plan for dealing with some of the things that you're dealing with. It's a work in progress. And the only thing I ask from you is you're going to think, this is a guy from a small country, government-run healthcare system. It's completely different. Just keep an open mind about that. So here's Scotland. Just over 5 million of us. In 1999, after a gap, a recess of 300 years, Scotland got its parliament back. How many people in the audience are pining for a Washington, D.C. recess of 300 years? We're organised into 14 regional boards. Those health boards are responsible for everything from public health through primary care and hospitals too. It's an integrated system. The money is allocated to the boards on an adjusted per capita basis. So we adjust for things like deprivation, rurality, etc. But per capita allocations, basically. It's tax funded and it's cash limited. So I've got about $18 billion to run the healthcare system. We can only spend it once. And I can't overspend. I probably could overspend once. Then you can all guess what would happen. People get equal access to care on the basis of need, and care is free at the point of care. It's kind of like an ACO, I think. It's an accountable care organisation. It does that across the full continuum thing. It's responsible for population health. We're increasingly integrating that beyond healthcare into social care. We've got some clear quality aims that we need to deliver. I'm accountable to the Parliament. In fact, my formal title in that accountability role is the Accountable Officer. And likewise, our boards are accountable to their populations, to the extent that we require them once a year to have a public accountability meeting. So we advertise it to the local population, the board sits down, we ask them some questions about their performance, all of their data is published transparently. So I hope you agree, it sounds a bit like an accountable care organisation. We're tackling these 6 big challenges, and Susan touched on some of these this morning. I think you're tackling more or less the same kind of challenges. We're operating in a political environment. The politics of Scotland just now is really about whether it should be independent from the rest of the UK. Your big political issue is around the Affordable Care Act and Obamacare. But we've got political issues to deal with. We just have to accept that. We operate in a political environment. There are some big economic challenges, which I'll come back to in a second. There's that demographic tsunami, I think Susan called it this morning. Those significant demographic changes that are heading our way. Some big changes around the epidemiology of the population that we need to take account of. Some particular challenges for us around public health and population health. And then I think a very underestimated point that the expectations of the people that we serve are changing. Let's just reflect on some of those. Before I do, just to point out that, so Scotland's not on here because the OECD don't recognise us as a country. So there's the UK there. Scotland actually spends about the same as Iceland per head of population. That's about half as much as the United States. Just hear what I say in that context. And this looks a kind of nondescript little chart. But you hear people talking about bending the spend. So this was a bend in the spend over which I had no control. So that's my cash. That's my cash spend historically, and it's my cash budget going through to 14-15. It's still increasing, as you can see, but the rate of increase has slowed dramatically. So like you, I was accustomed to having 7 or 8% per year additional to spend. Now it's 2 to 3%. In real terms, for the first time ever, it's flat, or if anything, slightly reducing. So we were faced with the prospect of that back in 2009-10, and we figured out that we should do something about it. Because I think in these situations you get a choice. You can either choose to plan, or you can just choose to respond. And I guess that's the situation that you find yourselves in now too. Reform is coming. You can't change the fact that reform is coming, but you do have a choice about whether you plan for it or whether you just respond to it. If I was you, I would choose to plan. Here's some of the demographic changes that I was talking about. So that's what the population of Scotland, that's what the population of Scotland looked like back in 1911. That's the projection to 2031. Here's the baby boomers, now appearing as people aged 65 plus. I always think that looks like a supertanker. And it's heading my way. You're not far behind that. That's heading your way. A little bit slower than it's heading mine, but it's heading your way too. What's your plan? We've both got some big public health challenges. So this is Scotland, this is male early mortality for chronic liver disease and cirrhosis. That's our advertising slogan for the tourist trade that we don't use. Scotland, the cirrhosis capital of Europe. Doesn't really work, does it? And you can see we're starting to make some inroads in that, but we've still got much higher rates of liver mortality than any country in Western Europe. Here's your equivalent. You've got higher levels of obesity than any other country in the Western world. We can either plan to do something about those kind of public health challenges, or we can just respond to them. Here's another growing issue for us. This is an analysis that was done by our Scottish School for Primary Care of multimorbidity. And look at that trend in here. And think about that in the context of the slide I showed you about the aging population and how rare it is now for older people to have no long-term conditions or only one. The vast majority have more than one long-term condition. I don't know about you, but there are a completely different set of people pitching up in our hospitals now than used to be the case 10 years ago. A much more complex patient group with a whole range of needs and requirements. And so we need to think about how we're going to respond to that. And no one said it was going to be easy. We all know these people. And so here was the question that we asked ourselves. Faced with that bend in my spend, faced with those big kind of challenges, is the answer to those range of challenges likely to be one-dimensional? I don't think so. Is the optimal response to those kind of challenges likely just to lie in cutting costs, or just to lie in improving quality, or just in improving health? I don't think so. I think it lies in all three. And so what should we do as a result? So here's the first of my theories. This is the first of the sets of things that we're doing in Scotland and that might have some resonance for you as you think about how you're going to respond to the reform agenda, to the economic agenda, and to those kind of challenges that we've just laid out. That faced with those multiple challenges, the thriving healthcare systems of the future will be those that are able to blend high performance, strong improvement science, and what I call co-production. I'll come back to co-production. It's my Fosbury flop. It's the new thing in the mix. Those able to blend those three things to achieve the triple aim of higher quality care, better population health, and better value. And that triple aim is set out in this model by IHI, the three things that many healthcare systems are trying to achieve. Improved health, improved quality of care, and improved value for money. For me, the often overlooked part of that is this. And so for me, there is a power in doing those three things together. Not in putting them in separate silos and doing the best you can in each of the sections, but in trying to build a coherent program that's about all three. So on the right of this slide, here are the things that we've set out we're trying to do on the quality of care. These are our three Scottish quality ambitions. And here's at least one iteration of your quest. I think this is quest 2.0, but I could be wrong. Or this is the kind of history of quest. My point is, these are exactly the same things. The things that we are trying to do, that we've come independently to the same view about the kind of things that we ought to do to try and improve the quality of care, about making sure that we get better evidence-based care, reducing mortality, reducing cost, reducing harm, improving patient experience, and reducing readmissions. The key question you'll be asking yourself is it possible still to do those kind of things in that financial environment that I described to you? So have we been able, since we faced that downturn in our finances, to maintain the progress of quality improvement? Here's another way to put that question. Well, our experience is that you can. So remember, we started to see the downturn in our finances around 2008-9. And at more or less the same time, we started on our patient safety program. We set a baseline hospital standardized mortality number for 8-9. And there's the progress we've made towards it. We've had a nearly 12% reduction, 11.5% reduction in hospital standardised mortality since that baseline. If HSMR had continued at the baseline 1 number, then there would have been 7,500 more than expected deaths, more deaths than we've actually experienced. Now, that doesn't sound like a huge number, but remember the population of Scotland is 5 million. So if you scale that up to the United States, that's close on 400,000 fewer than expected deaths. So we think that's a good performance, which has continued, indeed, as this shows you, has accelerated in the difficult financial times. So hospital standardised mortality is reducing everywhere. That's what people told us when we started to show these reductions, and indeed it is, and ours was reducing too at about 1.5% per year. But over the last couple of years, since we got this patient safety programme to all of our hospitals, and that's one of the key differences between what we're doing. So what I'm showing you here is the average number for Scotland. It's not our best hospitals, it's not our worst hospitals, it's the average number for Scotland, because all of our hospitals are in the safety programme. All of our hospitals are in our quality improvement programme. It's not like Quest where you can choose to be part of it or not. All of our hospitals are part of it. And because we've gradually built the kind of capacity that we need, the rate of improvement has tripled in those difficult financial environments. So as a board member, as you're thinking about how are we going to maintain the improvement over the difficult financial times, all I really want you to do from this is take some comfort that it is possible, it continues to be possible, to make care safer, even if the financial environment is tighter. Here's our performance on C. difficile, a very destructive organism, as you know. We've had a 90% reduction in its incidence in our general wards. I could have chosen a whole host of data to show you from our patient safety programme. That some of our intensive care units have gone years without ventilator-associated pneumonias or central line infections. There was a few months over the last 12 months where we had no central line infections in any intensive care unit anywhere in the country. My point is, you can continue to make the improvement even when times are tough. This is a thing that people often ask me about. So they'll say, I'll show them that data, and they'll say, okay, well, you can improve safety in your hospitals, but people have to wait for ages to get into a hospital, don't they? And at one time, that was true. So look at our performance there back in the middle part of the first decade of this century. Frankly, it was a national disgrace that people had to wait that long for care. This is where we are now. And remember, this is elective inpatients. So these are patients who are coming in for elective surgery. If someone has an emergency, they get seen on the day they have their emergency. And we have a performance target for our emergency rooms that 95% of people get seen within 4 hours. Once they get into the emergency room. So these are people who are waiting for knee replacements, hip replacements, elective surgery. And the average now is 25 days, median wait. And 90% of people are seen within, 55 days. And what my clinicians are telling me is that's low enough. That's why it's kind of flattened out there, because no one's saying, you need to cut waiting times further. We need to maintain them at that kind of improved level, but no one's saying we need to cut them further. So don't believe the press you hear about the United Kingdom and its waiting times. It's not as bad as everybody makes out. It used to be terrible, and now it's much better. We've also been trying to focus on making improvements in primary care. And I'm just going to show you a couple of charts now from the Commonwealth Fund's survey of sicker adults, 2011 survey. And And so one of the questions they ask the patients are, do you believe you have a medical home? They define what a medical home is, and it's about continuity of care. And you can see there that of all the countries they surveyed, the Scottish patients were most likely to say that they had a medical home and they experienced continuity of care. And there's the US number there, 56% compared with our 83%. So we asked them about, had you had any gaps in your care? And again, very few people, there's Scotland over there at 17%, people saying that, yeah, they'd experienced some gaps in their care. And again, the US up over here somewhere. And then the final question I asked them in this section was, had you experienced any shared decision-making? And again, lots of Scots saying they'd experienced shared decision-making. This is a function of the fact that we've invested very heavily in trying to move care out into the communities. And I don't know how much the premier hospitals have thought about shared decision-making. But if you haven't, my advice to you would be to start thinking about it. I think it's one of the bits of evidence-based care that's in least practice. The evidence-based for shared decision-making is very strong indeed. Be warned, though, that patients tend to choose less invasive procedures if you involve them in the decision. So shock if you leave the decision down to an orthopaedic surgeon, usually they'll choose orthopaedic surgery. If you have a conversation between a patient and the care team about what might be best for me, then a range of other options are opened up. So let's move on to population health, the second strand of that triple aim. What are the things we've been trying to do in Scotland that might have some resonance for you? Some of this you'll not be able to do. This is one of the benefits of having a government-run healthcare system, is you can take legislation. So we're in the midst now of setting a minimum price for alcohol in Scotland. It's okay, though, those Premier members who are visiting Scotland later in the year, that the legislation won't be through by then. It's currently being challenged by the European Commission, who think it's a restriction on free trade. But it's really about the fact that people are able to buy cheap alcohol and drink to excess and do the kind of damage to their livers that I showed you earlier. Something you could do is think about these alcohol brief interventions. We've been trying them. So we try to make every engagement with a healthcare professional an opportunity for one of these alcohol brief interventions. If someone pitches up in A&E, for example, and they're clearly under the influence of alcohol, the consultant will talk to them about their alcohol use. We'll try and make that encounter about being about their health as well as about their care. We've made restrictions on tobacco sales and availability, and I'll show you some results from that in a second. And we've just introduced this thing called the Early Years Collaborative. Of all the things we're doing in Scotland, I think this is the most exciting. But it's only just started. We had the first learning session. Those of you who have been involved in the collaborative methodology will know how this works. We had the first learning session last week. It's a multi-agency, cross-public services collaborative. It involves healthcare, but it also involves social work, third sector organisations, the police, all coming together to try and reduce infant mortality, to improve social attachment for children, and to increase readiness to learn. A huge programme with tremendous potential, and something that we're desperate to succeed. Lots of people say, I don't know why people bother with the population health stuff. It all takes too long to come through. It's for a generation, hence, rather than for immediate impact. My needs are much more urgent than that. But you should have a look at this piece in the New England Journal of Medicine, which it was a follow-up study to the introduction in Scotland of a ban on smoking in public places. And the impact that had on, so there's the ban there, the impact that had on childhood asthma. Of all things, childhood asthma was almost immediate and significant. It really surprised us. And so it's not always the case. There's a mythology that doing something about population health takes you down a slower track. And I'm not sure that stands up to scrutiny. The other thing that focusing on population health helps you with is tackling issues that are around deprivation or particularly challenged communities. And this story that underpins this reduction in coronary heart disease, and particularly the reduction in coronary heart disease, the quicker reduction in the most deprived communities of Scotland, something we've been trying to do for many, many years and have failed. The thing that lies behind this is a very, very simple, targeted screening program called Keep Well. Because what we found was that people in deprived communities tended to come forward for care much later in the disease's progression than people in more affluent communities. And so what we did with the Keep Well program is instead of waiting for them to come to us, we went to them. So we set up stands at football matches. We went to the social clubs. We just went to find people wherever we could find them, and we offered them a targeted health check. And actually, many more people took us up than we ever thought would be the case. Both that example I've given you about the childhood asthma and this one now about coronary heart disease are not only good for the health of the population, they're good for the healthcare system. Because having fewer admissions for childhood asthma is good for hospitals. Having people come forward for care in a less ill and with reduced morbidity must be a good thing for hospitals. This is still a huge challenge for us. And this is why we in Scotland have to be focused on this, because life expectancy in Scotland is still amongst the lowest in Europe. But the thing that gives us hope is that gradually we're closing the gap. So the dark blue line is the EU average there, and you can see the gap between Scotland and it. Much bigger, even 5, 6 years ago, than it is now. So we've still got a gap to fill, but we're going to try and fill it. So my second theory is really about the integration of all of this. If you're thinking in your boards about how you're going to respond, my advice to you is to try not to think about that as being a response that's just about cutting costs, or just about improving quality, or just about population health. But think about it as a response that's about all three. Because I'm convinced that there's a synergy to working on all three. The big question is how. And I've been trying to encourage my boards back home to think about the how in these three terms. And that what the future is about gathering capacity and competence under all three of those curves. Historically, we've worked well here. We've balanced our books. We've met our key performance indicators. We've published good annual results. We've been gradually working in this kind of territory. We've been doing the performance over time. We can show run charts like the one I just showed you on safety. But increasingly, my view is that healthcare systems need to get into this kind of territory. Need to be thinking with their communities about how we're going to deploy all of the community assets at our disposal. Where does the hospital sit in the life of the community? And how can we utilize all of the assets that the community brings? So when I talk about co-production and assets, these are the kind of things I mean. That every person in your community and every part of your community has a value to you. And one of the questions you might want to ask your community is, how are you going to contribute? Given the challenges that lie ahead of us, how can we make our endeavour a shared endeavour in this community, rather than something the community does separate to something the hospital does? And the task for people like me and people like me in Washington is to make sure that the policies that we set enable people to work with their communities and build those assets. And I think about this always as trying to make that demographic tsunami something else. Because if you think about it, we're going to have a whole group of people who both want to make a contribution in their retirement and are able to make a contribution. And what's more, we also know that enabling them to make a contribution will be good for them. So why wouldn't we want to turn that demographic time bomb on its head and think about how would we deploy those resources? So why performance? We need to keep getting the basics right. You only get the room to move into the improvement space by meeting your targets. You can't really pursue quality and co-production without that. Why quality? Because there's waste, harm, and variation in your system. There's waste, harm, and variation in my hospitals, and there's waste, harm, and variation in yours. That poor quality costs you more. The other reason why it's important to focus on quality, I think, is it's the route to clinical engagement. It's part of that choice that we have about thriving or surviving. And why focus on prevention, co-production, and population health? I just can't see a sustainable route through all this without a radically different approach, without better utilising the untapped potential, I've called it there, of public activation. Some of the other things that we've learned as we've been trying to work our way through this is you need some enablers. I'm not going to go through all of these, but I do agree about the information thing. So this is just... I'll just flick through these quickly. So the information piece. Like you, we've got lots of data in Scotland about lots of pieces of the care pathway. And we've got clinical systems. We hadn't figured out how to do what Susan challenged us to do this morning and turn that data into intelligence. And all of the vendors in the world, because you know how this works, couldn't really convince us that they would be able to do that for us. And so we did build our own. We took all of our systems, we built an integration platform to connect them all, and we gave every clinician access, tailored access through a clinical portal. So all of the information gets into this integration layer, and then there are permission rights from every clinician into that. We can scale it up, we can scale it down. We've started to be able to share that information right across our system. So regardless of where you happen to be, you'll get some key information on every patient. So the patient might have their domicile in Glasgow and become sick in Aberdeen, which is several hundred miles away. The A&E consultant in Aberdeen will get access to that patient's records through this key information summary. And so too can our telephone triage people, our ambulance staff, and potentially a whole host of others as we move into that early years collaborative. The next domain for us really is working with patients, figuring out what a patient portal would look like, what kind of information would patients need to play that strong role in co-production. And actually, it's not the kind of things that historically people tell you about, I need to have access to my records. It's much more about how can I make appointments, how can I order my repeat medications, How can I communicate with the caregivers, etc. So the third leg and the final bit for me is about costs and what do we know. There are several bits of research that tell you that poor quality is costly. One of the difficulties in getting it out of the system is that the costs and benefits are spread over time and between stakeholders. And the amount of cost that you can get out of the system depends very much on the context. But just look at this. This is data from Pennsylvania, from an organization that collects all the data from all of the hospitals in Pennsylvania. And they looked at cases with infections and cases without infections. And look at the difference in both the quality measures, the utilization, and the cost. So, case with an infection, average charge $306,000, average Medicare payment $20,000. Cases without infection, $37,000, $6,500 Medicare reimbursement. Why would you not want to focus on quality faced with those kind of numbers? Why would you not want to drive C. difficile out of your system faced with those kind of numbers? We've tried to bring all of this together in a piece of work that's called our Long-Term Conditions Collaborative, which really emerged from the work I did that Charles referred to on my Hartness Fellowship. This is what it turned into. And it's the one place where we've managed to bring all three of those elements together. So we do risk prediction using whole systems data to predict who's most likely to be at risk of admission to hospital. We have anticipatory care plans for those people who are at risk. Every board has a delivery plan that sets out how it's going to deal with these at-risk populations. We've built new contractual requirements into our primary care contracts. We've, as the name suggests, the collaborative, we've applied improvement science, and we've introduced co-production through supported self-management. The results are good, fortunately. So here's the Scotland number. Like everybody else, our bed day rate for emergency admissions was increasing. We introduced the collaborative, and it's on the way down. It doesn't matter whether you were a poorly performing board, like our Borders board there, or a high-performing board like Tayside, the trend looks the same. What that has meant for us is that we've been able to save 550 beds from our system. Just from that simple initiative. That's a big hospital for us. We've only got 32 hospitals, acute hospitals. And so the avoidance of 550 beds is a big deal for us. Here, I think, is the basic choice for us. If we work in that concerted way, we can focus on the thriving. We can think about how we deploy all of the assets at our disposal. If we only focus on reducing the costs, focus on the 3% efficiency savings that all of my hospital boards need to make every year, if that's all we focus on, we might survive. I'm not sure that we'll thrive. Charles was really keen for me to leave some time for questions, and so I'll do that. And I'll leave you with that image. Does anyone know the problem with the salami slicing? Eventually, you run out of salami. Thank you very much for listening. So, are there any questions? Nope. Yes. I think there's a microphone back there.
I'm sure this isn't a short answer, but how did you fix your access problem, the wait time issue?
In a couple of ways. Firstly, we threw a lot of money at it. So we bought a lot of extra capacity. Secondly, we made sure that as we were doing that, we redesigned the system. Took a lot of the hurdles and barriers out of it. Thirdly, we made available to people options. So back pain is a good example. The only option people had for back pain was going to see an orthopedic surgeon. Actually, that's not what most of them wanted, and it's certainly not what most of them needed. And so we made a much more diverse range of options available to people, including some that were non-medical. But it took us several years of concerted effort of building extra capacity, redesigning the system, taking all the hurdles out, and then redefining the service offering.
Sir, could you tell us how you manage provider supply, both how you use advanced practitioners and how you get the proper deployment of primary care versus specialists across your network?
Yeah, so we employ all of our hospital doctors, but we contract with the vast majority of our primary care doctors. So they are self-employed, independent contractors in the main. We employ some, but only about 10%. We've recently introduced some greater flexibility around advanced practice. So we're testing a range of advanced nurse practitioner models, for example. Like everybody else, we figure that's, again, part of the answer to the sustainable future. Not without its challenges around regulation and a bit of kind of protectionism within the professional groups, but definitely something we have to do.
In the United States, a small number of patients disproportionately require resources. Can you talk a little bit about your approach to end of life, to complex care, palliative care, and those kind of things?
Okay. So it's the same in Scotland. 5% of the population account for over 40% of the spend. It's the same kind of patients. People tend to be at towards the end of life. We have available for people palliative care. It's a choice that a lot of people make, but we don't require it. It's not the only thing we'll offer them. There's a lot of talk about death panels, etc. I'm not familiar with any concept of a death panel. People get the care they want and need when they want and need it. What we do try and encourage people to do is have the conversation about end of life. What would they want to have at the end of life? And part of that key information summary I showed you is a section that's about, here are my end of life choices. Here are the things I would like to die at home. I don't really want CPR, etc. Or alternatively, I really do want CPR. Try anything you can do to keep me alive for as long as I can. We try and have the conversation with people. We try and document the choice, and then we try and meet the choice.
How about high utilizing people who aren't at end-of-life care, case management and other modalities?
Yeah. So part of our anticipatory care planning is exactly for those kind of people. That long-term conditions collaborative I spoke about had at its core, how can you predict that kind of need and then anticipate it, rather than just respond to it. I know there are people who want to play golf, so we've got probably time for one more question.
One of the challenges that we face here in the U.S. is we often add benefits or new technology at a fairly rapid pace. Two examples. State of Oregon just added a mandate to commercial insurance for sex change operations and the morbidities associated with those. FDA just approved a new drug for treatment of melanoma, adds about 4 to 6 months of life at many hundreds of dollars per month that are now being folded into benefits packages. Is there any mechanism in Scotland to deal with those issues?
Yeah, two. So we've got something called the Scottish Medicines Consortium. People might have heard of NICE, which is the UK equivalent, the National Institute for Health Excellence. So the Scottish Medicines Consortium looks at all new drugs and takes a view on their efficacy and their relationship in terms of quality and cost to the existing drugs for that particular condition. And it will improve drugs that will either improve outcomes or reduce costs, and it won't approve drugs that neither improve outcomes or reduce costs. And we have a similar organisation called the Scottish Health Technologies Group, which looks at new technologies in the same kind of way. So if we're offered something that either improves outcomes or doesn't reduce outcomes at lower cost, we're interested. If it does neither, it won't be approved. It won't get onto the formulary.
Well, thanks again to Derek for this informative session.